Hello everyone, we are back with our first live for 2022 Fertility Q&A Live. I'm going to go ahead and try to invite Dr. Gelman on and see if we can get this working so we can jump into our questions for tonight, because we have questions, so many good questions. I'm excited to jump in. So Dr. Kenneth Gelman of IVFMD will be joining us tonight. And I do see that he's on here as well. Awesome. And we're going to see if the IVFMD Instagram can join us so that everyone over there can see and ask questions as well. So for those of you who don't know me, my name is Duro. I'm a licensed acupuncture physician, reproductive oriental medicine specialist, and we are Florida Complete Wellness. We work with women and couples trying to improve their fertility via acupuncture, Chinese herbs, nutrition, stress relief treatments, massage, many modalities, and we integrate with the treatments such as the ones that IVFMD offers. And yay, we've got, okay, I see them right there. So I think we're getting closer, guys. And let's go ahead and see if this works. I think, oh, darn. Okay, so Dr. Gelman, it says IVFMD is unable to join. So we're gonna just see if we can just pop you on. So I'm gonna go ahead and invite you on your other account, if that works. So let me see if, let's see, I've invited both the Broward Fertility Expert and the Kenneth Gelman MD account. So we'll see if we can pop on there. And if not, this is like our glitchy start to 2022, guys. So
there you go.
Oh my gosh, you got it to work. Excitement. Okay, this is from are you on your account or on IVFMD's account?
I think it's my account actually.
Okay, hey, we make it work, so that's good.
Yeah.
So maybe we can have Shirley just, share that that you're on your account so people can come in and watch and ask questions. Yay, right. We did it, guys. All right.
Wow.
How is your 2022 going so far?
So far, so good. So far, I'm on IVFMD. Shirley just said so. So I guess it worked.
Okay.
After
awesome.
all. Yeah.
Okay. And we just want to wish everybody a happy 2022.
A happy New Year. Mm-hmm. Yeah. And we always have to have a glitch at the beginning of the year, right?
I know. Okay. It wouldn't be a good Wednesday night without a little glitch.
Absolutely.
And we hope and pray that this year is going to be even better than next year for you guys.
Yeah.
We are here for you, and we have lots of questions to dig into tonight. This might go a little over because we have so many questions. So we're going to go ahead and jump in, if that's all right. And I think we could start with just, the questions that were submitted a little earlier in the week. Right. And the first one's about scar tissue. So how do you get rid of it for good?
Well, what are they referring to? Scar tissue where?
I think that just says scar tissue. I guess maybe the uterus, perhaps. It doesn't have a lot of details there.
Well, that usually obviously requires surgery, and you need very capable, good surgeons. It's called Asherman's phenomenon, probably. Maybe that's what they're referring to. But there are experienced surgeons, reproductive surgeons, who deal with this all the time. And that requires, hysteroscopic removal. So, but the doctor has to have a lot of procedures done under their belt because they need the experience, because, anytime anybody goes in and operates, whether it's in the uterus or anywhere else, you can create more scar tissue.
Yeah.
So, they have to be very careful. So obviously, when polyps are getting removed, things like that, you could create adhesions or tissue in there. So it all comes down to the experience of the surgeon, but it's a surgical problem.
Okay, that's good. Yeah, and myomectomies, they're not as common anymore. It seems like before IVF. As they used to.
Depends. Yeah, they are. Again, myomectomy is all dependent upon location. Fibroids are all about location mainly. Mm-hmm. And size to a certain extent, but location.
If they're small, you'd rather just leave it alone, right?
If they're small and not in a way, but if it's a centimeter fibroid sitting right in the middle of the uterine cavity, that has to come out. But if it's a small one sitting in the body of the uterus, that's not, distorting anything, and the cavity looks good, by either hysteroscopy or an SIS saline infusion, you leave it.
Yeah. Yeah, well, interesting. And okay, well, that was our first question, and we have many more. So we're gonna kind of jump in because we have some questions about COVID. As you know, the rates are skyrocketing, and
Oh my God, yeah.
in our area and everywhere around the world. So what if you have COVID right now? You're not transferring. If you have COVID or mild COVID symptoms, that's a question on here. Like, how long after having mild COVID should we wait to do a transfer?
Well, I don't think anybody really has a definitive answer on that. I think I would probably wait at least a month or 2 months probably before I got a transfer and made sure, I felt well and, all that. And, obviously the prep has to start.
Mm-hmm.
So it's probably going to be a period of 2 months easily before you get a transfer after getting over COVID. So I think that's not unreasonable.
And to tie in with that, there is someone who just commented that their wife has had her FET and she's now COVID positive. Does this lower risk of implantation?
No, it shouldn't be. I mean, as far as what we can experience so far, it has not affected those kinds of things. I mean, they're obviously recommending getting the vaccine too, even in, pregnancy, et cetera. You don't know if you're breastfeeding. And, the people who've had COVID, from my experience, some of my patients haven't had any issues, luckily.
Mm-hmm.
So
And it
it's been like a bad cold or a flu.
This is a
And
milder strain.
they've done okay. The vast majority, 95% of this that's out there now apparently is this milder strain.
Mm-hmm.
But who knows what's coming down the pike now.
Yes, and you want to feel well. Continue to take the things that you need to take for your cycle and that sort of thing too. I would think prepping for that and vitamins and hydration and all those things.
Yeah, I mean, I think to a certain extent, I think vitamin D is probably somewhat protective from what I can see.
Mm-hmm.
Maybe zinc too.
Zinc, yeah, vitamin C, and a lot of these antioxidants that we recommend for good quality.
Yeah,
too.
yeah. I mean, I think I would definitely stay on those things.
Mm-hmm.
And make sure you're taking your vitamins and eating really healthy. I think it's really important to stay as healthy as you can be right now.
Yeah.
Limit alcohol, limit those things.
Never has self-care been more important.
No, I think it is. I think it really is. No question.
We have a question about PCOS. No period for 4 months, was on Prometrium and still no period. What's the next step? I guess it depends on what treatment they're doing. I'm not sure.
Right. Sure. I mean, obviously, maybe the Prometrium's not working. And maybe you need a change in your progesterone product. Maybe a medroxyprogesterone or Provera might be a better option for you to get a period going. But again, it depends on what kind of treatment you're looking for here. And if the Prometrium isn't working after 4 months, always do a pregnancy test too. Make sure you didn't spontaneously ovulate and get pregnant, and maybe that's why it's not working.
Good point. Yeah. That's good. And there's a debate about, how long should you go without a period? And,
well, you should,
6 months.
I think ideally I tell patients with that to have, I think you should expect probably 6 menstrual cycles a year minimum, I think is not unreasonable.
Right.
But preferably every month, I think is better.
That lowers the risk of endometrial cancer, and just to have them.
Yeah, 6 a year, you're not going to get endometrial cancer like that. And the people who get that really are much higher risk with other comorbidities. They're obese, they're smokers, diabetics, things like that really haven't had periods for a longer period of time. That would probably raise their risk a lot higher than somebody like this.
And sometimes we've had patients that are on Prometrium that combine it with the acupuncture, and they do get more regulated that way as well, like with electroacupuncture, like a stronger version of the typical acupuncture.
Right.
And,
that might be a good option too.
Mm-hmm. There's some research showing that electroacupuncture, abdominal acupuncture, and along with auricular acupuncture, that actually can help the HPO axis kind of get going and get everything connected again. So that could be also another option for this person too. So, and then as far as the, okay, we get egg quality questions a lot. So we have an egg quality question about, is there anything to improve it? What is your like thoughts about what's been helping, or have you seen many things improve as far as like medication, supplements, or anything like that?
Well, I mean, egg quality is basically determined by a lot of things. I mean, probably the majority of poor egg quality is age dependent. As we see women age, certainly over age 38, 39, 40, certainly over 40, we're really going to see that happening. And that's sort of a biological phenomenon. That's not something you can really change. But
Mm-hmm.
what you can do, or what the theory is you're improving or keeping the good eggs that you still have healthy. Because you can't really, change biology. We can't, turn the clock around and change things back to when we were all 21, which would be nice, right?
Yeah.
But we can improve the health of our organs and blood flow and things like that with the idea of, maintaining what we've got left. Because, we know from statistics, at age 40, maybe 70% of eggs may not be good quality anymore. But, that means 30% are. So what do? We try to maintain those 30%. So we still have chances of getting pregnant. So that's where, healthy diet comes into play. Mediterranean diet comes into play. Acupuncture comes into play. Stress reduction comes into play. All those things. And try and maybe DOR supplements to a certain extent. So these are the things we would recommend.
I was looking at research from 2020, just kind of going back into 2020, 2021. There's been a whole lot of acupuncture and IVF research. I actually didn't even know about some of these studies, and I was like, oh, and a lot of them are looking at anxiety. So they're looking at the correlation between the levels of anxiety, because 80%, they're finding 80% of women undergoing IVF have anxiety. And it could be related to that, or it could be other factors. Is it going to work? There's a lot of things like going into it. And what happened is they found that each subsequent treatment with acupuncture reduced the anxiety scores. And then the patients who had the lower anxiety scores actually had the higher pregnancy rates. So interesting.
Right. And also there was a study I saw recently, actually, in one of the medical journals that looked at the effect of Mediterranean diet as well as a stress reduction program.
Oh,
They looked
interesting. That's good. Yeah.
on small for gestational age infants. And that, they think that a big part of that might be due to inflammation of the placenta, because of, poor diets, stress factors, high cortisol, insulin resistance, blah, blah, blah. And those features, those particular things, a stress reduction program for several weeks beginning in the second trimester, as well as, acupuncture is included in that, as well as a Mediterranean diet, vastly improved the risk, vastly reduced the risk of small for gestational age infants.
Oh, that's interesting. Yeah. I mean, makes sense. We've all been fighting and fighting with COVID and all these things for like the past 2 years or going on 3 years. And there's interesting things about how it affects pregnancy and all those things. So I think if you're looking into it, you might, want to do some search on like, what can I eliminate in my life that's actually causing me to have a little bit more stress than I need? And it could be being around toxic people, toxic things.
Yeah. If you ask anybody that, they can say their job, I'm sure,
Yeah.
but some things are not going to change, and
Yes,
so your job, if that's the most stressful thing, you're not going to be able to eliminate that, chances are.
Right.
So you have to work around these things. And I tell patients, you've got to work around these things, because if you're not healthy yourself, how are you going to help yourself and help others? You're not going to be able to do it.
You got to have an outlet somehow, and I think that's really important in this process too. So those are some interesting studies, and I think a lot of them centered around like frequency of acupuncture, which is another question we just had, like when to have it. When they looked at studies that actually only had it around the day of embryo transfer, they actually did not have as much success as they had when they were doing acupuncture prior to the transfer. And a lot of the studies were only like limited to 3 treatments. So we only saw like, and then the other ones kind of went in more depth, and they actually went through the whole stimulation process and to transfer as well. And those success rates continued to go up, which I thought was interesting. So, so, you know, at the minimum, we would say 3 treatments. If you can only do those 3 treatments at all, you would, you know, hopefully get 1 week before, which is one study that actually came out. I think it was in Taiwan, where they said basically they had 1 treatment the week before, and then 1 treatment 30 minutes before that transfer, and 1 treatment 30 minutes after. So, you know, that's a bare minimum, I would say. And that, even that alone, they had a 63% pregnancy rate in the acupuncture group and a 33% in the control. I thought that was pretty interesting. And
that's a big difference.
Yeah, and significantly reduced anxiety scores. So just those 3 treatments, like if you can, yeah, like just if that's all you can do, or let's say you don't live anywhere near an acupuncturist, you just need to, you know, you're coming in and having those 3, that would be when I would time it. But I would recommend, you know, going in a little earlier to try to work, especially if you've had a cycle that was not successful, or you had, you know, multiple issues going on, and you know, you definitely need that extra support. I think that takes that anxiety score further and further down, enhances uterine blood flow, enhances ovarian blood flow if you're stimulating, and then it can modulate the immune system a little. So that those things are all helpful and protective if you're able to do that. So what we recommend is usually that 2-month period prior to stimulation, if you could, you know, do acupuncture usually weekly. And then as you get into STEM, you're doing twice a week if possible with electro acupuncture, which is a little bit more research than, you know, our regular acupuncture. So it can have a little bit stronger effect on blood flow, which they measure with Doppler. So I would say like that would be great. And, you know, then the other question, I'll just like finish the acupuncture questions, is when to do it after, like when you're pregnant, like how often should you be coming in? Most of the time, you know, we see patients weekly during that first trimester, because a lot of people are dealing with nausea, vomiting, or you know, perhaps the beginning stages of that. And we're doing acupuncture to help with that, and also for pain relief too, because they don't want to take Tylenol or Advil or any of that. So we're trying to work with migraine support, back pain, all those things. And still anxiety, right? Because you're still anxious. Like, is this test going to be okay? Is my ultrasound going to come out all right?
Yeah.
Like, well, you know, what about all these other tests that I'm having to do? It's so that the stress doesn't like automatically diminish when you get a positive pregnancy test. So we are working with our patients usually in their first trimester if possible, and then as needed. So sometimes once or twice a month during pregnancy. So that's one of the beneficial things. And then towards the end, we try to support them like prior to delivery. So that's what we try to do. So every, you know, practice is different, but I think that if more people could kind of think about other solutions to, you know, pain relief and nausea, vomiting, all those things that are natural, like prenatal massage and acupuncture and those stress relief, meditation, yoga, all those things would be great and very supportive for pregnancy as well. So, yeah.
Absolutely. 100% agree with all
that. We have a little question that popped up right here, so I'll go ahead and post that. Can you discuss the pros and cons of medicated versus natural FET? And when would a natural cycle be recommended over a medicated FET?
Well, you know, when you look at pregnancy rates, they're pretty much identical with you know, medicated versus natural. So, you know, one or the other, I think I do natural cycles in certain situations when, for example, I think that maybe some of the PrEP medications aren't working as well as I think they might be working in that particular individual. And maybe that individual's history is that, you know, they perfectly ovulate, and, you know, maybe we've followed them in some natural cycles. We know their lining thickens beautifully, and or maybe they've gotten pregnant on their own and they're coming in for, you know, having trouble with the second, you know, so that would suggest to me that, you know, they have the ability to ovulate and mature their lining and have implantation occur. So, you know, that person, you know, theoretically, we could probably think about a natural cycle transfer. But, in terms of our practice also, you know, because we're batching now in Cooper City, it makes things a little difficult to actually get the transfer done, you know, in Cooper City when you're doing a natural cycle, because we don't know when you're going to ovulate. And, you know, we do the transfer 5 or 6 days after ovulation. So that person may get, you know, moved to a different location. And if they've had frozen embryos, we have to move them up and back, you know, it gets a little cumbersome. So, you know, the vast majority of people do pretty well with the preparation medications where we, you know, we plan the cycle transfer directly. So that way that we have an exact date that we're going to do it, and, you know, it works out for everybody's schedule too. So, and again, the pregnancy rates are pretty much identical. So, you know, it can be done in certain circumstances, but I don't routinely do natural cycle transfers.
Okay. Yeah, it's more of a convenience than issue, right? Or, but not like necessarily a higher pregnancy rate, you're saying. So, and then,
right.
Let's see here. We have a few. Let's go ahead and get to some of the questions, guys, and we're getting there. I love the questions here tonight. We've got okay, a question about I have big follicles and was both bigger than 18 centimeters, but I just had my period a few days ago. Bummer. Any tips? Big. Okay, so I mean, I guess like I'm not sure about if there's a medicated cycle or if it was natural, but there were follicles present. Sometimes it doesn't mean they're good quality though, but they could be, or that they matured, right? But I guess
what is her question?
I'm not sure, like any tips, because she did not get pregnant. She had a period, but saw, you know, that they were bigger follicles, I guess, than normal. I don't know. I'm not sure. Adele, if you want to just type in a few more details too, that would be helpful. But I mean, that's frustrating sometimes if you see that you are responding, you're getting follicles, but you're just still not getting pregnant. Like it could be so many other factors involved, right? And that, you know.
Yeah, it's hard to interpret. I don't know exactly what they're trying to ask.
But type in some more information. We'll try to get. Oh wait, let's see if there's more. Okay, no, I didn't see that. Okay, we'll have one more question here. Does high progesterone levels from day 21 labs indicate conception?
No, it doesn't. But it obviously indicates a good ovulation, but it has nothing to do with fertilization per se. So, you know, it's nice that you had good levels and maybe you will get pregnant, but there's no definitive way to tell that, you know, until you do your pregnancy test, obviously, or if you're doing a natural cycle or an IUI or whatever it might be. Yeah. Even you know, IVF cycles, you know, those cycles are medicated. You know, we give you progesterone, so we're expecting high levels. So it doesn't always mean you're getting pregnant, unfortunately.
Well, we cross our fingers and hope no. So good luck with that. That would be wonderful, and it would be nice to have an early sign of some sort, you know. But there is nothing until you get closer to really give you that definitive answer. But, there is a question about first failed IVF, fair quality embryos. We did not do PGT transfer. Total 6 eggs, like 6 total eggs retrieved. First round failed. How common is this?
What was that again?
First failed IVF, and they had fair quality embryos, and they did not do PGT. And they had 6 total eggs retrieved from the first round that failed. And they want to know how common is that, and we're sorry for that.
Well, again, depends on a lot of factors there. I mean, obviously, if that person has diminished ovarian reserve, if they're older, you know, 6 eggs might be a reasonably good result for somebody who's 42. You know, and, you know, we're going to expect poor quality in a lot of those eggs. So, you know, but that person probably should try another cycle because, as I said, you know, 42, while, you know, maybe 70, 80% of those eggs may not be good, we still have some good eggs left that we would try to recruit again, you know, but again, depends on, you know, a lot of things, on finances, emotion. Are you ready to do another cycle? And, you know, could the same thing happen again? Yes. You know, so you have to be prepared for all that when you go forward with this. But again, it's not impossible, and we've gotten 42-year-olds pregnant, so it's not an impossible situation. If that's the person, if that's the age of the person, I don't know how old she is.
Yeah,
But there are some people with DOR who are quite a bit younger, where we struggle with this situation too.
yeah.
And that would require another cycle, most likely, and with the hopes that we could do better.
And then sometimes you will pull those and do like estrogen priming, right, to kind of get.
Well, you try it. It has its advantages to a certain extent, and other times it really maybe doesn't matter.
Yeah.
But again, that person, we have to go over a lot of factors there to see what we can do to make things better. Maybe back off on some of the gonadotropins, try something gentler, see if we can just maybe get less eggs, but better quality eggs. I mean, that's a theory too. So that might be one thing we could try on that person. But again, depends on a lot of factors. I don't know all the details.
In this one, I have a little bit of a lengthier question. So we'll start with, that was a message through Instagram to us, and I think I sent it to you earlier, but it involves a DNC. It looks like, no, it was actually a endometritis situation. So it was a person who had a retained placenta from vaginal birth that was removed via hysteroscopy in December of 2020. And then the endometrial biopsy from that cycle showed that she had 4 plasma cells. She was given antibiotics as precautionary and did a sonogram in the summer of 2020 before the transfer that was clear. She then transferred a PGS high-grade embryo that resulted in a chemical miscarriage after 3 excellent HCG blood results. Did a biopsy in this cycle after the miscarriage, showed greater than 10 plasma cells. Currently on antibiotics. My questions: could the miscarriage have caused the endometritis? If I had endometritis, would the embryo have even implanted?
Yeah, I mean, that's a good question. I mean, that's very possible in that situation. It sounds like it was not treated well enough the first time, so that when you had that transfer, you had still endometritis present, which might have gotten a little bit worse. More plasma cells there. I mean, you might need a follow-up hysteroscopy, because sometimes the SIS studies, aren't completely definitive, and maybe in that particular circumstance with that history, maybe a hysteroscopy would be better for you, where the surgeon can actually look in there and see if there's any areas of concern before you do anything else.
The endometrial biopsy, it looked like it was done, after, but there's not. I don't know. She also said,
well, how soon after the miscarriage did you have the biopsy?
Yeah.
I mean, I assume maybe a little bit of inflammation might be due to when you're miscarrying, if it was done right away. But if it was done weeks later, I assume once your beta is all the way down and maybe you had a period already and they did a biopsy after that, and you still have endometritis, there must have been some inadequately treated endometritis in there that maybe contributed to your, the implantation failure. I would think it might have.
I don't think there was a biopsy done before the transfer, because she's asking, would you have done a biopsy before the transfer, or would you recommend?
Well, before the next one, I mean, as I said, before your next one, I would do a hysteroscopy, I think, because I would make sure that went away, because apparently they thought they treated it adequately the first time. And I guess you had an SIS or something and it was normal. But it wasn't detected. Sounds like.
Yeah.
So before her next transfer, I would do a hysteroscopy, I think.
It's tricky. It's so tricky with that, because you don't have any symptoms at all. Like, it's so frustrating. Endometritis.
Yeah. Plus, it'll save you a biopsy again, which is painful, and they can do it under anesthesia. So, and plus check out the cavity a little bit more. That's what I would do.
So that was an in-depth question, but I think there's a lot of components to it. So if you're hopefully you're seeking help, and you're getting, you're getting help, because it's really painful to go through all this and end up in a miscarriage.
Oh, absolutely.
And
Especially
not,
with a normal PGT embryo.
yeah,
That's
yeah,
very tough, you know.
hmm
So before you do another transfer, make sure everything is adequately looked at.
yeah. Right. And we have another question in the chat here. I'm 35 years old and having endometriosis stage 4 and 4 surgeries. Is it possible that IVF can get positive results?
Oh, well, yeah, I mean, I would hope so. I mean, I think that that's what you would need for sure. And you know, again, that's got to be we got to look at your AMH and your ovarian reserve, and you know, hopefully they didn't operate on your ovaries and take out too much ovarian tissue, and you know, but definitely I think it could be done depending on again what your ovarian reserve is. Your age is in your favor, so I would definitely go right to IVF. I wouldn't do anything else to try to get pregnant.
Yeah, and definitely we've seen patients in their mid 30s with stage 4 endometriosis, and they've had to have successful
Of
pregnancies with
course.
IVF.
Of
And so,
course, you know,
yeah,
and you'll need a frozen transfer. You'll have to do, freeze your embryos and then do a frozen transfer, and then make sure the endometriosis is quieted down as much as possible before you transfer. But there's definitely successes with those cases.
there's a lot of little tips and techniques you guys have in your
Yeah,
tricks up your sleeve for that to calm everything down.
yeah,
And sometimes
you
it
have to
takes
do
several
that
months.
before you
Mhm.
transfer. So no
Yeah,
fresh transfers.
yeah, yeah. And then there is a question about do you recommend IVF at age 46?
Well, with a donor egg, but not with your own eggs. I mean, it's gonna be not a successful process at all. No, most people, most places, maybe a few around the country would take your case with your own eggs, but majority of places would not, and they would, offer you egg donor, which will give you a very high chance of success. But unfortunately, at that age, there's too much what's called aneuploidy, and the chances of a successful implantation are pretty close to zero.
And it's
So nobody would do that.
right. Yeah, and there's some research saying, look, it's not like people do get pregnant in their 40s, and they do have, but
Well,
those
occasionally, of course,
it's
somebody's
occasionally,
going to
yeah, but
spontaneously ovulate at
right,
46, 47.
right, yeah.
That happens. We all know that, but that's, very rare.
But in this case, there's lots of research showing that IVF is not successful at that point.
No, it's not. We're not. Nobody's going to, have somebody spend so much money and time and give them all these drugs,
Mhm.
and have them spend X number of dollars for, a futile process. So it's really not going to be done. Certainly not at our practice.
I feel like we need to have a few. I want to get our patients to come on, like some of them, to talk about their experiences with the donor cycles, because I feel like that the patients we've seen, like who have done donor cycles, and they're in that age range, like 46 to 48, 49. No one's ever looked back and said, I wish I had never done this. Like nobody, they have had the best
No,
experience.
they're all
And
very happy, and
mhm,
I say that to every one of them that comes in, and we know it's not your first choice, but
yeah,
it's a very, very, very good second choice,
yeah, yeah.
and nobody's going to know the difference.
Yeah, no, it's incredible. That's what we have technology. A lot of people have said,
Yeah,
I wish that someone told me to freeze my eggs. You
yeah.
know,
Well,
uh,
unfortunately, um, maybe 15 years ago, I mean, the technology really
yeah,
wasn't there.
yeah,
And it's also, for a recent technology with vitrification, all that these things really can be done with a fair, high degree of success.
I feel
Um,
like you guys need a campaign, like a poster to put in all the
well,
OBGYN offices.
they did do that. They did
Oh,
do
okay.
that.
Oh,
I don't know, maybe I don't know how many years ago it was. I think there was a billboard on 595
oh,
about that,
oh, okay.
and there was a women's group that didn't like that apparently, so
Oh,
they took it down. So, I
okay.
think it's really up to patients to, educate themselves, really. There's
Mhm.
nothing like self-education,
Yeah.
and hopefully their OBGYNs give them a little bit of time.
Yeah.
Because they're the ones really on the front lines to counsel patients about stuff like that, because that's really where it comes from.
Yeah. Yeah. We try to turn back time as much as we can, but sometimes there's a limitation to wish we could like warp speed back.
Well,
time
it's also, most women that, should do this are in college or out of college, right out of college. And, maybe they're on their own now for the first time and they're working, and, it's going to be a tough thing to afford financially, or, all of a sudden give them another X number of dollars to pay for egg freezing. And then, that's adding to their college loans.
Come on, insurance, we need to cover
this.
And
insurance is not covering it unless you're working for Apple or Amazon, maybe.
Yeah, that's true. Yeah.
So, that's another problem.
Mm-hmm. Well, but there are so many more options for sure, like out but then there were even 10 years ago. So I think, yes. How will no one know the difference? Someone is saying the baby won't look like the mom.
That's not true.
Interestingly, it is not true, because I have seen,
not true.
Like, we are always amazed. We're like, oh my God.
Because you'd be surprised out there. The donors in the World Egg Bank and places like that, you can find somebody almost exactly like yourself. It's ironic.
Mm-hmm.
And one woman showed me a picture of her donor.
Mm-hmm.
This was a few months ago. Can't remember when. It was her exact double.
Oh my gosh.
Exact. I mean, exact.
Yeah.
And so it always comes out looking like the parents. I mean, obviously the father is the father, and so it really is. Nobody knows the difference.
Yeah.
Zero.
Yeah, and then also you have less, like when you get to the OBGYN's office and you say, yes, I did a donor cycle, like those patients are looked at differently, I think. They're not seen as such a high risk than, someone who possibly could have more genetic issues and that sort of thing.
Yeah, I mean, it's obviously a good thing obstetrically too, because, it's not the uterus generally that's the problem, it's the egg. I mean, so theoretically they won't, they will, because they'll end up seeing perinatology because of the fact that they're older patients that are higher risks. Well, they still have higher risk for, hypertension or preeclampsia or complications still. So they will be seeing, perinatal specialists, but theoretically, most of them done well. I've not really heard of any donor cases had any real problems during pregnancy.
Yeah, definitely. So at least, just it's like keeping an open mind, right? That's what it is. So
yeah.
There's even embryo adoption as well. Like that's a whole other thing that, I learned about recently. I didn't know. But, for patients that are looking into an egg and a sperm donor, it's like you look at it and go, okay.
Well, embryo adoption can be done. It's just hard to do. It's like a real adoption.
Yeah.
And it becomes a pretty kind of cumbersome process, actually. It takes a long time.
Oh, interesting. Okay, so that's something we need to learn about, to discuss a little more, to be open to discuss it. And I think the more that we can talk about this and create a little bit more awareness of all these different options, the better. And I think, that, we don't want to...
No, it definitely benefits patients. And we have people coming in that want to adopt embryos all the time. Mm-hmm. And they work through certain agencies and things like that. But it takes a long time because, you're going to get scrutinized just like you're adopting a child,
Yeah.
And just plan on it taking longer than the frozen egg bank, which you can get done probably in 3 months.
Okay. Oh, yeah, that's interesting. So, and that would just basically be like a normal transfer, a frozen embryo transfer.
Yeah. Oh, yeah. Yeah. Very easy.
Okay. And so we are getting through our questions, guys. And we have, I think, a few here. We've already answered those. Okay. And then we have a few questions about IUI. Second IUI on 12/26. Can I take a test now? Oh, okay. They're wanting to take a pregnancy test, and they said that the second IUI was on 12/26. Or should I wait a full 2 weeks? Was today the 5th? I think it's.
Well, I would wait the
early,
2 weeks,
right?
and again, sometimes, and we've handled this question before. Sometimes people do these early pregnancy tests that they sell now, where several days before your missed period, you can detect HCG. And there's probably, it all goes back to the realization that probably 50% or more of pregnancies that happen are missed pregnancies, that don't really happen at the time of the missed period, quote unquote. That there may have been some kind of fertilization, but yet it didn't implant, so, and that's true that, as I said, majority, like a lot of pregnancies, people get pregnant, but they just don't implant. Most people will never know that they actually got pregnant. So I would not do any of those tests early, because she'll get, possibly a false sense of security there. And I would just wait for your proper day and do the test in the doctor's office and get, blood beta level.
And how long does the trigger shot take to kind of get out of your system? To like about a few
Well,
days?
depends on which one you got.
Okay.
The HCG is a longer acting shot, which we don't typically use. The Alvedrol is much shorter acting, so that's out of your system. But still, you want to avoid that little window there where maybe the beta is a little positive, but yet it's not remaining positive at the time of your pregnancy test.
Okay. There's a couple of questions we need to get through these, because we have these were submitted earlier on Instagram. So we have a question about for 34-year-old with diminished ovarian reserve, do you typically recommend PGT?
Well, that's a good question. It's diminished ovarian reserve in this particular situation, just means that she's got a low amount of eggs. She's not producing eggs like a typical 34-year-old, or, but theoretically, it's not the quality, it's the number. So, 34 years old, the data shows that PGT is not necessarily going to increase your ability to get and stay pregnant. So if we can produce quality embryos, theoretically, you won't need PGT unless you want to do PGT. Some people want to do it because they're going through the whole process of, this retrieval and, all that, and drugs and everything, and they're going to store embryos potentially, and they want to know, we've done it all.
Yeah.
We know that the embryos that are in the freezer are genetically normal to the best of our ability. And if we come back in 2 years for another transfer, we know we're transferring a normal embryo. We don't want to have to worry. Or sex selection. For the second one, they want to know, they want the boy, or, whatever it might be. So, but in that particular circumstance, I don't think I necessarily would recommend it, because we're not that concerned about aneuploidy there.
Okay. That's good advice. Yeah. And just getting to that stage of the transfer is like the goal. It takes so much to get there.
That person's challenge is going to be getting the embryos in the first place.
Yeah. That's it. And we have a question about there was a patient who someone who typed in on the chat. I just got approved for gastric bypass, but I just turned 43 and I want to have a baby. I've had 2 miscarriages, I suppose due to my weight. If I decide to go with gastric sleeve, how long to try to conceive?
Well, that person is going to wait at least a year.
A year, right?
At
But
least.
Is that true for stimulation too? Like, can you do stim earlier and just wait for the
what's
transfer?
that?
Can you stimulate a little earlier than a year, or you have to wait a year to go through stimulation?
Stimulation probably can be done a little earlier, but that person's 43.
Yeah.
Probably not going to do much in terms of that person. That person, unfortunately, might have to use an egg donor.
Yeah, and I guess it takes time for the weight loss to occur after the surgery. I mean.
Oh, absolutely. So but theoretically, they got to wait a year after that kind of thing.
Basically, due to the procedures, effects on the body, or that sort of thing.
Well, the procedure, they need the healing.
Yeah,
to be done.
I mean, I'm just thinking, if you're 43, you are on that borderline of like, okay, this is the kind of cutoff stage of doing any, retrieval, right? I mean, or stimulation.
Yeah, it's a shame, but that's the at least in our practice, we're not going to necessarily help be able to help her except with an egg donor, most likely.
Mhm. Yeah, so definitely, but good luck with that. And I think that there
But,
are options
she's
like we
improving
talked
her
about.
health and doing good things. So
Yeah,
that's more important, I think.
yeah, definitely. And as far as we have one other question here. What's the benefit of one shot of Menopur on day 9 of Latrozole IUI?
Well, that's like what's called a mini stimulation, where, giving you an injection or a couple of injections will help just kind of boost the follicle size a little bit more, maybe mature the follicle a little bit more before you ovulate it.
Mm-hmm.
Give it a better chance of being mature at the time of ovulation so that theoretically it can fertilize. It's,
Okay.
it's a fairly standard approach that person's asking for cycles like that.
Okay. Yeah, and there's so many other like protocols and things out there that
Yeah,
that are there. But I think it depends on the person. That's why there's an art form to art, right? There's to each person,
exactly.
it's individualized.
Yeah.
What doesn't work, it doesn't work for your friend. What you're gonna do, or maybe you're doing something different from what your friend did. But everybody.
Yeah. I mean, I've done those cycles. I mean, it helps to a certain extent. It's just, the success rate of IUI in general isn't terrific, but we try to do everything we can to mature the follicle and make sure it's not a follicle problem,
Yeah.
or an ovulation problem, and then the rest is up to the sperm and the egg getting together.
We do have a question about someone preparing for embryo transfer, Claudia. I missed birth control pill and I'm spotting. Would this ruin the cycle? If you're for
Well, if you're on the birth control part of the prep, no, that shouldn't. We can repair that pretty easily. So that shouldn't be an issue because usually we start with birth control pills and we overlap Lupron, and then we stop the birth control pills. So and then we begin, estrogen, and then eventually progesterone. So no, that shouldn't really do much.
Claudia, you're still good, and you don't recommend doubling up or anything like that, right? As far as
Probably
that.
not, unless they're maybe starting to bleed.
Okay. Oh, yeah, that's what she says. She's having some spotting, so.
Yeah, maybe for a day or two, just give her an extra pill, but I wouldn't worry too much about it.
Okay, we have a thyroid question. Ideal TSH levels when trying to conceive. On Sun3 for Hashimoto's and most recent levels 0.7. That's pretty good, right?
That's a good level.
Yeah.
I'd leave it right there.
What do you look for? Like 0.5 to 2.5 or around that?
Yeah, well, I like it on like 0.5 to 1-ish, kind of in that
Mhm.
range.
Okay.
It's always better to be a little, I think, mildly on the, well, not hyperthyroid, but maybe towards the hyperthyroid range.
And it always can fluctuate. When you're pregnant, you always want to check that right away.
Well, generally a dose has to go up about 50%,
Mhm.
within 6 or 8 weeks in the first trimester because of what's called the TBG effect, where
Mhm.
a lot of the thyroid hormone gets bound up, so to speak. And you
Okay.
want to have enough free thyroxine to make up for that, so we increase the dose.
That's super important. I think most people
Yeah.
are aware that they need to have it checked right away when they become pregnant
Yeah.
and then every month.
OBGYNs are usually pretty
Yeah.
good at following that.
And oh, you're welcome, Claudia. She's going to see me tomorrow for acupuncture. Awesome. I look forward to it. And then there is a question from Iva. Is it concerning when follicle growth is very slow with stem? Sometimes it's not a bad thing, right? Or do you
No, I
think,
mean, you don't want to go too fast,
right?
but some people's patterns like that, and you don't want to start increasing dose of medications too quick and too much, because then all of a sudden, boom, everything takes off.
Yeah.
And then, you get it, the stimulation becomes out of hand. And you have to cancel it. So
Slow and
sometimes,
controlled is not bad, right?
no, it's
Slow
not.
and steady.
No, it's not.
Slow and steady wins the race. There you go. It's like the tortoise and the hare. There you go.
I know you, Iva. Don't worry, you'll be okay.
You're gonna be good. Yes, you got good support here. And we've got let's see, a few questions here that we have from earlier. Oh my goodness, there's so many questions, so many good questions. Like I want to get to all of them. I don't know if we're gonna have time to, but we have a few here. Okay,
Well,
so it's
we started a little late. We could probably
a
go a
little
little
late, yeah,
later.
so we're gonna just do a few minutes over, but I think
Yeah.
it's the beginning of the year, right?
No, we
We're going a
should. I
little
mean,
over
there was so
because
many questions. We gotta answer as many as we can.
yeah. And we have a question about baby aspirin. Do you always recommend baby aspirin for transfers and why?
Well, we do. I mean, we think that some of the data shows, it's good for your ovarian blood flow. I mean, if it reduces platelet adhesion, that kind of thing, blood flow will be better. I mean, if you don't have any GI problems from it, I would stay on it because I think, it probably will help to a certain extent. It might even prevent preeclampsia. I mean, there's some evidence about that, when you talk to your OB/GYN
And what
about
about,
that.
if you get COVID when you're pregnant, like that's a good thing to keep the blood thin, right? I mean, you don't know about how it affects the placenta.
Yeah. I don't know if any aspirin's been looked at.
It should
Um,
be though, right?
Theoretically, it might be a good thing. I mean,
Mhm,
with the clotting business that goes on, but that's usually due to, inflammation
mhm,
and not, well, I guess platelet adhesion to a certain extent,
mhm.
you know.
I mean, I remember reading an article about when someone looked at a placenta from a patient with COVID during pregnancy, how much blood clots they saw in the placenta and how
Yeah,
it degraded. And I just wonder if anyone is looking at that
I
because
don't know. That's a good point, actually.
so
That'd probably be a good idea to stay on it. And I hope the
um,
OB/GYNs are keeping people on it.
yeah. And then as far as the I guess we have a progesterone question. So someone's saying progesterone labs came back at 15 on letrozole cycle. Is this high or low or good or bad?
No, that's a good level. That's a good ovulation theoretically. So hopefully you
Anything
got
above like 12 or so, or what would you say?
15. Yeah, 12,
15.
15 is good. I mean, I think that's a good level. I would leave that person, and we wouldn't supplement them with any progesterone or anything. We would just wait and see if she gets pregnant.
And we had an acupuncture question which we answered earlier, but basically about the timing. Like if they're having a transfer on February 1st, that's going to be their second FET after a live birth. How should I start acupuncture? And if it's for an FET, it's usually fine to do once a week until we get like a month out from the transfer, which I guess is about now actually, or less than a month. Then we would do twice a week usually, but that would depend on your acupuncturist and what you guys do. That's usually what we'd recommend, and then continue on through to the ultrasound appointment. Usually when it shows a heartbeat, we go down to once a week, and that's usually for the first trimester. But that's something to discuss, and you can definitely customize it as you need to for your schedule as well. So. But if you don't get acupuncture at the transfer, we usually say at least try to do it as close as you can. Like maybe the night before you can go in, or the day before you can go in, or the morning of, but definitely not after. I don't think that it's very beneficial to rush off. Like we talked about this many times on these lives, to just like rush off to get acupuncture right after a transfer. You just want to relax a little bit. Don't fight traffic, and especially the crazy Palmetto and 95 and all that.
Yeah,
Just go home and
exactly,
relax and watch funny movies and
exactly.
chill out, and and then return to acupuncture usually like 4 to 5 days after the transfer if you're continuing on with your acupuncturist. So okay. And actually, I saw a study that was alarming. It was like someone who actually, I think it was an Iranian study, and they actually did two acupuncture treatments, one before the transfer, one after. They used two different, oh no, sorry, they used the same set of points, and these points were actually ones that we used to induce labor. So they were abdominal points that they were stimulating really strongly. And they showed that that second acupuncture treatment was not beneficial. And I think that you have to be really careful of the points you're using. We don't use any of those points, obviously. We don't do any abdominal points at that stage, and we're not strongly stimulating the abdomen either.
No,
Even,
I mean
you know,
that's you want the
yeah, it was
uterus as
really,
quiet as possible. That's the
it was,
benefit
yeah,
of it.
exactly. It was a
Why would
very
they?
strangely designed protocol. So, and definitely they said, oh, okay. And then they also were transferring day two embryos, which is
Yeah,
not really, done that much, I guess,
yeah.
anymore. But this was actually done last year, and I was like, that's interesting.
That's a little weird. Yeah.
Yeah, so they're strongly stimulating the points after transfer on the abdomen. Like, no.
Well, why
So
would
I
they
would
do
not.
that?
I'm not sure, and I don't know who thought of the points in this one, but I was kind
Yeah,
of like, no,
yeah.
no, no, no. Um, okay, so as far as what to do to increase ovarian reserve, I'm 38 years old, no children yet, um, and then the AMH is low.
Yeah, well, we discussed that.
Mm,
You're not going to increase your reserve. You're going maybe slightly. The AMH might change a little bit, and if that really reflects a change in the ovarian reserve, nobody really knows for sure, or whether that's just the assay changing.
mhm.
Sometimes you repeat an AMH in people and it goes up a little bit or it changes a little bit, and that may have to do with the accuracy of the actual level. So, it's not, again, like we're not going to increase the amount of eggs you have. You're born with a certain amount of eggs, and that's it. And you're losing eggs every single day of your life. You know, I mean, they say when you are conceived, you have 1 million eggs. And by the time you're actually born, I believe the number's down to 300,000.
Mhm. Isn't that
Yeah.
crazy how much
And
is
then, and
happening in
then,
your
and
life?
then, and then by the time you go through menopause, there's only 1,000 eggs left.
Yeah.
So,
Oh, wow.
so you know, you're losing eggs all the time, whether you're on birth control pills or whether you're pregnant or whatever it might be.
Mhm.
So we're not going to increase those. We're just going to again try to keep the ones you've got
Healthy.
healthy and accessible.
Mhm. Yeah, for
That's what
sure.
you're trying to do.
Very good. Yeah, and the diet recommended that she's asking about supplements, all this. Definitely, we talked about this earlier tonight. So
Yeah,
if
we
you
talked a lot
guys,
about that.
we're gonna post
Um,
this, and you can actually watch this if you missed the very first part of it. We were gonna, you can replay it, and it's, I think it was about like halfway through. We talked about that, about
oh
like
yeah,
things to do
yep.
for egg quality and that sort of thing.
Well,
So.
CoQ10, I'll just add CoQ10 is a good one.
Mhm,
I recommend 600 milligrams a day.
mhm.
High dose. It's expensive, but 600 milligrams, 200 milligrams, 3 times a day.
Yeah. Definitely. So, and yeah, there's a couple things that we talked about. So, I like there's actually a newer formulation of it's called FH Pro. I like that one a lot. It does have it has some CoQ10, inositol, alpha lipoic, antioxidants in there, and a prenatal. So, and melatonin, which is nice. So you can kind of take it before bed, and then are rested. And there's some research about melatonin with inositol to help during stimulation for PCOS. So I think that's something too that's nice, and they also have one for males as well. So there's different options out there now. So and we also use Chinese herbs, we use acupuncture, massage. The fertility massage is very interesting, and I've actually been doing some research into that because it kind of works in certain, obviously it works with stress, for stress relief, but also I think improving blood flow to the ovaries is a really nice thing to do if you are also stimulating or doing an IUI or that sort of thing. Prior to doing that, like trying to help those medications work better, like that's something that
Well,
we
just you just all the proof is in the pudding because when you talk to patients who are doing acupuncture, and I talk to them every day, it's night and day. I mean, every one of them says how much more relaxed they are.
Mhm.
And the main thing is when you relax, what happens? You know, your cortisol levels are lower, your blood pressure is lower, you're calmer, you have
Mhm.
less inflammation in your body.
Yes. Yeah, it's so important. I mean, just looking at, I'm going to post these studies throughout the month. I think I'm going to start being better at that. That's my New Year's resolution to start doing that because I looked at it and I'm going, there's 37,000 research papers published on acupuncture and
Yeah.
nobody's really seeing them. Nobody sees them. So like, and everyone's saying, well, how come I didn't know about this earlier? I'm like, I know it's really hard, but we have to be better at getting things out there. So if you guys please follow us, follow my
Well,
Instagram. I'm gonna
she
try
just
that.
said it right there. She's done fertility massage and she loves it. So
Yeah,
people ought to do it.
yeah.
Yeah.
So and we do it at our clinic. And
And
we have.
and 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 one other thing, somebody's asking about the CoQ10 again.
Mhm.
Yeah, ubiquinol. is the active form of coenzyme Q10.
Mm-hmm.
It's better absorbed. I mean, there's some stuff Qnol out there. It's expensive. I think that's a lot of marketing. It's a good formula.
Yeah.
But ubiquinol is the best absorbed CoQ10.
There you go. Yeah. Awesome. So and there's we're actually almost out of time, so we have like a few more questions. But there's a question from Claudia about getting COVID in December, and mild symptoms. Is transfer still okay? I don't want to delay the process. There might be a lot of those questions that you guys are
well,
right?
you can't really start until you have a negative test that everything's gone. And once you have a negative test, you can prep and start going. So it'll be, as I said before, 6 weeks before you get transferred.
Yeah. So I mean, because sometimes people do take longer to clear the virus than others. So still focusing on all the things that we talked about, all the things that are great for fertility to help with that. Like, I think they're helpful for, helping you stay healthy in general and having healthy cells and all of those. As far as, okay, let me see if we missed anything here. I think we got to most of these questions actually.
We did.
And I think on the previously submitted ones, we actually did pretty well with it. If we didn't get to your question, then definitely, let us know, or we can definitely answer that next time, because we'll be doing more of these throughout the year. So
well, we already have the schedule for the whole year.
Yeah, so we'll be excited. And then we also are going to bring on a little different, like we are going to bring on patients too, to talk and share their stories, because that is, everyone needs some encouragement. This is not an easy process. Our heart goes out to you guys for, showing up and doing the research and moving forward. And that's hopefully what this year will be about, is moving forward and helping you guys achieve what you set out to do. So definitely feel free to reach out to us. And Dr. Gelman is at Broward Fertility Expert, his Instagram, right? And then you can also reach him at
IVFMD.
Mm-hmm. Yeah. And then we're still doing virtual consults as well, right? And
we'll still do them. So
for this COVID wave, and the next one, and the next one, and the next one. But as far as we, really, I think that there are some things that are going to stay the same. Like, you can reach us via phone just for if you have a few questions. We do free consultations as well, just for like 10-minute consults, or if you want to reach Dr. Gelman's office, you can schedule a visit as well. And you guys do second opinions as well. I think that are free, right? If they have the information.
If you have your full records, we do free, free second opinions.
Yeah.
So we're happy to do that. So just make sure you send in all your records ahead of time.
Yeah. So another pair of.
And that's an IVF practice, from another IVF practice.
Yeah. Awesome. So I thank you, Dr. Gelman, for doing this, and thank you guys for your questions.
Thank you, everybody, and let's wish everybody a healthy and happy New Year coming up. Stay safe.
Yeah, stay safe, and we'll be back for another round. I think that we'll post this. I think we have another Q&A next week, but I'm going to double check with Shirley, and then we'll see you, Dr. Gelman, I think next month, right?
Next month, guys.
Okay. Bye, everyone. Have a good
night.
Bye,
everybody.
Bye.
Bye-bye.